Medurstand Understanding Medicine.
This is Professor Aziz Rehman from Medurstand, and today we're going to talk about this fairly common condition, depression or anxiety, or both, in general medical practice. So I'm not actually a psychiatrist, so what I'm presenting is a physician's viewpoint, because many patients with anxiety and depression, they first report to their physicians, and then if needed, they are referred to psychiatrists. So I think most of my talk would be about those cases which physicians see. What percentage of people coming to a family physician or an internist would have depression or anxiety as their primary disease or the main disease? You may be surprised, it is 30 to 40%. Although many people would deny, they would not accept this diagnosis that their symptoms are coming from anxiety or depression, but the fact is that they may have anxiety or depression. Maybe up to 50%, depending upon the type of your practice. So it's very, very common. It may be depression or anxiety just as a single disease, and that may be responsible for all the symptom patient have, or it may be a component of his overall illness. That patient may have diabetes, hypertension, other problems. Along with that, the patient may be depressed or anxious. So it has got multifactorial etiology. When I present this diagnosis to my patient, and when I say that it appears to be anxiety and depression, in most situations, the first response of the patient is, no, I don't have any reason. So what I tell them is that there is no definite reason required. It is actually multifactorial. It may come just from within your body, and in many situations, you are unable to identify a cause. Many people, they would think that they have an absolutely comfortable life. There's nothing to worry about, but still, their mindset may be such that they worry a lot. So I think, and there could be some reason. Somebody is seriously ill, somebody's loved one is ill, so that could be the cause of some financial problem, some divorce issues. They could actually precipitate depression or anxiety, but many times it is just without cause. So that is where you need to develop expertise to diagnose these cases. Clinical presentation, there are three domains from where the symptom can come, and I'm going to show you all those three domains and discuss them one by one. These are the three main domains: emotional domain, and then physical domain, and then cognitive domain. Patient wants to believe that the symptoms are physical in nature. Actually, many times symptoms are physical in nature, but the cause behind is actually some psychological problem. So let's first take up this one, emotional, because that is the most important. First of all, the feeling of sadness. Occasional episode of sadness is absolutely normal when things are not going the way you want, and occasionally a short period of sadness is absolutely normal. But when there is prolonged sadness without any clear-cut reason, that is a symptom of depression. Anxiety is being nervous and being too anxious about things. Again, anxiety up to a certain level may be normal. Anxiety in certain situations may be normal. But if you remain anxious without any clear-cut cause, or the cause is very trivial, but the symptoms are severe, then you call it anxiety. Then irritability, the person with anxiety and depression is very, very irritable, and that irritability would be manifested both in his physical actions, also in his expression in words. Then lack of enjoyment, and I think we enjoy so many good things, like we enjoy food, we enjoy so many things, but patient with depression, that person cannot enjoy fully the life, all the good things in life which are universally liked, and the person might not actually enjoy those things. So that would be a symptom of depression. Suicidal ideation. If somebody thinks of committing suicide, so much so that he has actually made certain plans, that is a very definite symptom of depression. And not only it indicates depression, it indicates a very severe morbid depression, and something has to be done, otherwise there's a risk of person actually committing suicide. Then hopelessness. We are always very hopeful, even if the things are not going in the right direction, we remain hopeful, and that is normal human behavior. But if patient loses all hopes, and then I think that is again a symptom of depression. Then inappropriate guilt. Feeling guilty about something you have done wrong. That of course is a normal emotion. But if you are feeling guilty about something which is very trivial and which is not actually your fault, that would be considered a symptom of depression. So this was the first domain, emotional, and now we are going to take, I think, the physical one. In physical domain, patient may feel fatigued. Now, of course, it is normal to feel tired or fatigued after hard physical work, but patient with depression would feel tired, would feel lethargic, even in resting condition. Even if they have taken good rest, they have eaten, they have taken their favorite drinks, but still they feel tired or fatigued. That is a symptom of depression. That could be symptom of some organic disease also, but mostly this symptom indicates depression. Then eating abnormalities or weight changes. Everybody has a certain eating pattern. If there is very significant change in one's preferences for food, patients start eating too much or stop eating, and that results in weight swings. That may also be a symptom of depression. Insomnia or hypersomnia. Insomnia is lack of sleep and hypersomnia is excessive sleep. If there is significant change in your sleeping hours, that could again represent depression or anxiety. Then sexual dysfunction, inability to perform sex, or even more important, loss of libido, the loss of desire of having sex, is another very important symptom of depression. And then psychomotor agitation. Patient feels agitated all the time. Psychomotor means patient would have very irritable thoughts and expressions, and motor means that his movements will also be very fidgety and will be moving his hands and arms and eyes. That would be a symptom of depression. Pain, very important. Pain is usually due to some physical cause. If there is some trauma, some inflammation, some other thing, that is usually the cause of pain. But very interestingly, there may be pain in the entire body on certain points, and there may not be any physical abnormality associated with it. And you examine the patient, accept that there are certain tender points, there is no other abnormality, and you go through the lab test, again there is no abnormality. In fact, this condition, when you have pain as the predominant symptom and you fulfill certain criteria, it is called fibromyalgia. Fibromyalgia is a symptom of depression. Now, please do not confuse fibromyalgia with many other diseases where you could have generalized body pain, like ankylosing spondylitis, rheumatoid arthritis, SLE, many other diseases where you could have generalized pain. So you don't want to confuse a physical condition with the physical symptom of depression. Stomach problem, if you feel pain in the epigastric area, and if you feel bloated, and if you feel pain in the abdomen, or with the cramps in the whole abdomen which are relieved by defecation, that could be a symptom of depression. So that was the second domain, physical domain. And please note down, you can't make a diagnosis on the basis of just one symptom. It has to be your collective judgment. You consider all the symptoms, and all the symptoms, they do not have the same weightage. Like I told you, suicidal ideation has got a lot of weightage, whereas feeling of little irritable may have less weightage. So I think your experience will guide you to make a diagnosis. And initially, you always make a tentative diagnosis, and you keep your mind open to accept an alternate diagnosis, and you always consider a physical condition before you jump to the diagnosis of depression. And now let's take up this third one, cognitive. Cognitive is something related to your higher mental function that could also become abnormal in depression. And what are the features in cognitive? Attention and concentration. Now, of course, when you are interested in something, when you are watching a movie, when you are listening to the news, or when you are attending a lecture, you are attentive and you are concentrating on that thing. If someone loses attention and concentration, that could be the symptom of depression or anxiety. Then short and long-term memory. Of course, there could be physical condition like dementia, Alzheimer disease, other diseases where you could lose memory. But even in depression, you may develop some loss of memory. The reason is that the patient with depression remains preoccupied. Now, if somebody is preoccupied, that person might not actually register the things happening around him, so he might not remember. So that is why there may be dementia. This is called actually pseudo dementia. Once depression is corrected, the dementia is also automatically correct. Judgmental abnormalities may also be featured. Then decision making, again, patient with depression makes very, very irrational decisions. So that is important. And then planning and organization. All these are actually cognitive function. All these require very high level of our mental faculties. They are affected because of depression. Then mental sharpness. So I think thinking speed in a normal healthy person, sometimes you make a right decision in a fraction of a second because your mind works very, very fast. But in people with depression, they may take much longer time to come up with a decision, and that decision might be actually wrong. So these are three domains: emotional domain, physical domain, and cognitive domain, from where the symptoms come, and you could make a diagnosis, initially tentative, and then you can apply certain tools. I'm going to show you some tools which are applied to make a more formal and more definitive diagnosis of depression. And these are the tools, and these are developed by different authorities, different societies, universities. And first, second, third, fourth, these are the questionnaires which a patient can himself or herself see these questionnaires and can make a judgment if that person has got some depression or anxiety. And all these scales, I will not go into the details, and frankly, I don't know the details of these questionnaires. All these are available online, so you can just follow any of them and you will get certain score, and that score will tell you if you are depressed or not. And these two are more professional tools, and these are usually applied by the psychiatrist, the physician, or their assistant. So they are more definitive tools. So on the basis of these, you can make a diagnosis of depression. Of course, you have to rule out physical conditions by appropriate examination and the laboratory test. What are the laboratory tests for depression and anxiety? In future, there might be some, but today there are no tests actually. We go by our clinical judgment. And sometimes tests may be needed to rule out a physical condition, associated physical condition or cause of depression, but there are no tests required for the diagnosis of depression. Now, there are some further questions and points which are important. Number one, you must give it a serious thought. Is it really depression? Don't jump to the diagnosis. It is possible that patient has actually a physical abnormality, like somebody had a heart attack, somebody had a stroke. Naturally, that person would be depressed. So in that case, depression may be part of his other condition. So in that case, that might just require little assurance or short-term treatment. Or is it part of another brain disorder or systemic disease? So that is another question you need to ask yourself. And then, did you provide proper privacy to the patient? Privacy is patient's right, and you cannot expect sensitive information which are going to lead to the diagnosis when you do not provide privacy. If a couple visits you and one of them is suffering, I think you first interview the couple and then you ask that person if he would like to have privacy. I think in that case, the other person, attendant, he or she should volunteer to go out, or you can ask if they could provide few minutes to talk to the patient in private. Now, first thing you assure the patient is confidentiality. I think, especially in our culture, if a father brings his son and then you ask the father to go out and provide privacy to the son, you must, I think my first statement is always that whatever you're going to say is going to remain confidential with me. So please say whatever you want to say, and this will not be shared with anybody. So only then patient will come up with the personal information, the drug usage, cigarette smoking, alcohol intake, sexual abnormalities, other problems, the relationship problem with the parents and the relationship problem with others. So I think only then you can get useful information. Then empathy, that means that you must connect with the patient's feeling. Empathy is not the same word as sympathy. You must actually feel the person's, you must show from your body language and from your gestures that you are very concerned and you want to solve the problem. So that is empathy, and only then if you show empathy, only then patient will share personal information. Systemic review, of course, you consider every other possibility before you make a diagnosis. Physical checkup is extremely important. In many situations, during interview, we have already made a diagnosis of depression or anxiety, but before you present that diagnosis to the patient, you must give him a good physical checkup. For two reasons. Number one, there is actually a possibility that your judgment was wrong. Patient actually has a physical condition. And number two, once you present the diagnosis of depression and you had gone through a thorough physical checkup, patient would then believe your diagnosis and will more likely follow your advice. So I think a physical checkup and some laboratory tests may also be needed. What is the pathology of depression? I think it is actually a physical disease presenting in certain psychological symptoms. What is the evidence that there are physical basis on some very sophisticated investigations like functional MRI? Some changes have been detected in various parts of the brain, like anterior cingulate cortex, hippocampus, many other areas, even cerebellum. So I think certain parts of the brain, they show abnormalities, abnormal signals, abnormal metabolic features which are not seen in normal people, and they could indicate depression. So there is something physically going on in the mind, in the brain, which results in depression. Second question is, are there any biochemical basis of depression? Of course, the answer is yes. And the evidence says that many therapies, other than psychotherapy, many medical therapies, they are based on certain principles, and we try to actually raise certain neurotransmitters. And I'll give you some example. For example, serotonin is our happy hormone, and if the level is low, then we feel sad and depressed. And there are many drugs like tricyclic antidepressant drugs and this SSRIs, selective serotonin reuptake inhibitors, and some psychobiotics. They improve your serotonin level, and that results in improvement in depression. So that indirectly confirms that there was some drop in their serotonin level at the synapses or in the blood. So that is the evidence. Then epinephrine. Epinephrine is a hormone which is produced by many parts of the body, and mainly the adrenal medulla, but all ganglions, they produce epinephrine, and epinephrine is also a mood elevator. That if the level is dropped, then we might feel depressed, and there are many drugs which try to increase your norepinephrine level. For example, this selective norepinephrine reuptake, serotonin and norepinephrine reuptake inhibitors, venlafaxine and duloxetine. So these are also effective, indicating that epinephrine level has got something to do with depression. Then dopamine. Dopamine is also a neurotransmitter, and many antidepressant drugs, they try to increase your dopamine level. Bupropion or MAO inhibitors like phenelzine, these drugs, they increase your dopamine level. Now, when we are treating depression patient, we are usually using multiple drugs. They act through different mechanisms. We try to increase these hormones, these neurotransmitters, to make them feel happy. So when now coming to anxiety, first thing is an anxiety a normal human emotion? Yes, it is. It is actually very, very useful emotion, because it is the anxiety which makes you work so hard. And imagine the examination days. Nobody can study for 10 hours, 12 hours in normal days. But during examination, it is your anxiety which makes it possible to work that hard and study that long. So anxiety is actually a normal human emotion. But if it is too much, now if there is somebody has no symptom, no reason, but feel anxious all the time, or there are some physical component associated with this anxiety, then it becomes a disease. So normal anxiety is useful function, but abnormal anxiety becomes counterproductive. What are the symptoms of anxiety? There could be psychological symptoms, or there could be physical symptoms. In psychological symptoms like restlessness without a cause, inability to concentrate, or sleep disturbances. These are classical signs of anxiety. In physical domain, there could be tachycardia, there may be tremor, there may be headache, there may be dyspepsia, bloating, heartburn, or there may be feeling of dyspnea, shortness of breath, or there may be diarrhea. So all these symptoms could represent anxiety, provided there is no other known condition which can explain these symptoms. To give you one example, a hyperthyroidism can give you all those symptoms which we see in anxiety. So don't miss hyperthyroidism. Similarly, people with pheochromocytoma, they could have in certain phases these symptoms. So first you rule out physical condition and then you consider anxiety as a disease. Depression and anxiety often coexist because they both are related to mind, although they have separate diagnostic criteria, separate treatments, but many times they coexist. Why it is important? If they coexist, it may be a good idea to treat them with something which can treat both anxiety as well as depression. So they many times coexist, like in this case. Thank you very much, and this concludes the first part. Please join me in the second part also, which will discuss the treatment part. Thank you very much.